So I want to thank Dr. Farrell for moderating the session and kind of hosting this educational seminar for the primary care physicians and referring physicians to ROSM. Our whole goal here this evening is to talk about identifying patients that fall in the orthopedic treatment gap. What is the orthopedic treatment gap, and what options are there to help these patients that are in this treatment gap? So I would like to introduce Dr. Farrell. He is a non-surgical orthopedic physician, primary care sports medicine physician, really specializing in sports medicine. He's a co-founder and management for ROSM. He's also the team physician for the DC United, and he served in the Navy for many, many years, and so we really thank him for his service. And he was educated at Penn State, MedStar, and Fairfax Family Practice for his fellowship in sports medicine. So with no further ado, I will turn this over to Dr. Farrell.
Thank you, Amisha, for the wonderful introduction. Going to get control of the screen. We'll go to our next slide.
I'm just going to give you the keyboard. Just 1 second. There you go.
No problem. There we go. Well, Amisha kind of gave a little bit of background about me, but I'll just kind of fill that in some of the gaps really quickly. So I'm a native Washingtonian, grew up in the Washington, D.C. area. UMBC was my undergrad. After graduating there, went to Penn State for med school, go Nittany Lions. And I was lucky enough to have a rich uncle pay for med school, and that was Uncle Sam. So I spent, after doing my general surgery intern year, I spent 4 years in the Navy. And that was during my time in the Navy that I realized that I'm not really sure if I still want to go down that surgery path. I wanted to kind of find a way to kind of help people in a non-surgical way, but still treat a lot of the athletes and patients that had musculoskeletal injuries. So that's when I found primary care sports medicine, and I went to MedStar, in MedStar, I went to Franklin Square for residency, and then I did my primary care sports medicine fellowship at Fairfax Family Practice in Inova. And that's when I had a chance to be exposed to some of the professional athletes. I got to spend some time in the training room with the Redskins. We got to do spring training with the Nats, and I got to cover DC United for that year. And then after I finished my fellowship, I stayed on as a team physician for DC United for about 3 years, and then went on to be the team physician for the Washington Spirit for about 3 years. And then now I'm currently kind of covering the DC Divas. So as Amisha kind of talked about, the purpose of kind of hosting this meeting is, one is I want to help providers and referring providers kind of figure out what patients really kind of fit in this treatment gap. And we'll talk a lot more about that treatment gap. I also want to kind of talk about, one of our strongest tools that we have in our toolbox is kind of non-surgical orthopedics, and that's really what this LipiGEMS kind of procedure is for us. We also kind of really understand that a lot of providers really don't kind of understand the stem cell world. They have patients that come, they ask, I saw this webinar, I saw this seminar on stem cells. Is it safe? Is it effective? Does it work? So we wanted to just kind of talk a little bit about what is the science behind that, what is the data behind it that really kind of supports it. And then we want to talk about what's FDA approved, what's not FDA approved, and also a little bit about the indications. So as far as my relationship with LipiGEMS, I first got introduced to LipiGEMS approximately 2014. Before then, I had some experience, injecting fat in the musculoskeletal areas because we shared space with a plastic surgeon, Paul Ruff, and he would do liposuction on his patients, and then we would take that leftover fat and we would inject it into Achilles or knees. We would actually get, really good, results with that. But, that was hard to set up for a lot of our patients because not everyone was signing up for plastic surgery. So when we saw LipiGEMS in about 2014, this is really the first kit that we saw that was self-contained, and that was something that we could do in our own office. And so we've been kind of using that since that time, and we've done a number of patients with really good results. And, it's really kind of changed the lives of some of our patients who have had chronic, musculoskeletal pain, and are able to get back to having their pain-free lifestyle, being able to lose weight, being able to spend time with their kids. And it's been really a game changer for us. So let's talk a little bit about orthopedics and, this COVID-19 pandemic. So COVID-19 really changed a lot of things for us. We had to shut down surgery centers, shut down any elective procedures in the hospital. And it really became kind of a pretty large financial burden on both, providers trying to keep your practices open, trying not to lay off your staff, as well as, for patients because they were scheduled for surgeries, they were scheduled for procedures, and they were still kind of suffering in pain without having, great treatment options. So let's talk a little bit about this orthopedic treatment gap, right? So these are patients that are suffering from some type of musculoskeletal condition, and they've kind of failed conservative options, but they're not quite ready for, a major surgery, or they're not an appropriate candidate for a major surgery. They might have, other comorbidities that prevent them from really being a good candidate. So if we take just knees alone, there's 3.6 million people in the U.S. that suffer with kind of knee osteoarthritis. This is a 17 billion annual economic burden to the system. And what we find is that some of the reasons for this treatment gap is that the ineffectiveness or the conservative measures that they can help out in the short term, but not necessarily long term. And we find that on average, the duration of that treatment gap is that people are in this gap for about 9 to 12 years before finally going under a total knee replacement. There's even some studies that show that that can last for up to 20 years. So what are people waiting for? Why are people scared to kind of go and just get this knee replacement? Well, here's an interesting study kind of looking at elderly patients who asked what were their concerns about signing up for a total joint. About 50% of them that were worried that they might die after that surgery. About 74% were concerned that it would be very risky. 71% were concerned about the complications. 84% were worried about the long-term recovery. 77% were worried about the pain or discomfort from the surgery. And another 77% were worried about needing help from others. So these are all valid concerns and valid points. And so people have some hesitation. So they stay in that treatment gap for longer and longer because of some of these worries. Now we're going to switch gears a little bit, and we're going to talk a little bit about some of these so-called stem cell clinics, right? So when we look at everyone who's kind of offering stem cells across the U.S., the number one condition that they're offering for is orthopedics. So if you haven't, it's not going to be long before you have one of your patients ask you, hey, what about stem cells for my knee or for my hip or for my shoulder? So of the groups that are kind of advertising stem cells, there's some that promote autologous, cells coming from the own patient. But, 1 in 5 advertise allogenic. And so these are cells that come from, or these are injections that come from amniotic material or placental tissue or even umbilical cord. So we had a couple of interesting studies done on amniotic tissue. And what they found is that there was no living cells when we get this amniotic tissue. So this amniotic tissue might come micronized into little powders. It might come frozen. You have to, de-thaw it before you inject it. And, what they found when they did the study is that they tested about 5 different amniotics. They tried to plate them on agar and try to grow them. They were able to plate MSCs, or mesenchymal stem cells from fat, and mesenchymal stem cells from bone marrow, and able to get both of those to grow. But when it came to these amniotic products, none of the cells grew. So that tells us that there's really no living cells, and this really shouldn't be marketed as a stem cell product. Then they also looked at the growth factor content. And what they found is that on average, for a lot of these products, the growth factor content was actually less than the growth factor content that was of PRP. And what we know is that the FDA is not going to allow any of these amniotic tissue companies to continue to market themselves as a stem cell product unless they have a BLA or a biologics license. And then there's very limited data in the amniotic space in the orthopedic world. Now, going back to some of these so-called stem cell clinics, here's an interesting study that looked at stem cells, clinics marketing themselves as stem cell clinics in California, Florida, and Texas. There was a total of 608 clinicians. Of that 608, 34% of them were not physicians. All right, so you have a third of them that don't even have an MD or DO. And then of the groups, the 157 groups that did have a physician that were marketing as a stem cell clinic, only half of them actually had a physician on their team with formal training in the condition that they match. So what does this mean? It means that there's a lot of clinicians out there that are providing these so-called stem cell interventions, and they're practicing outside their scope of their medicine. And then, we worry about some of these unlicensed providers, really kind of causing a risk and not knowing exactly what they're doing when it comes to this. So FDA has put out a published warning, and essentially there's no approved stem cell therapies in orthopedics. And so people are saying, well, why am I doing this talk? Well, lipogyms is not really considered a stem cell treatment. This is a fat graft. And we'll kind of break down some of the differences a little bit later. So going back to kind of dealing with this new normal, because of COVID-19, a lot of us have had to modify our office flow. We may not have the same number of patients kind of coming in and out of the office as we did before. And, we've been trying to find ways to kind of stay in touch with our patients, through telemedicine, through phone calls. But we've also been trying to find ways that we can help them get out of pain while limiting their exposure to hospitals and to surgery centers. And so this is really kind of where lipogyms kind of fits into this treatment gap. All right. So when we talk about orthopedic diseases, the natural progression is you start off with conservative therapy, then you have some minimally invasive options that you can do in the office or a procedure room. Then minimally invasive surgical procedures. These are typically your knee scopes, your washouts, your cleanouts. And then you have your major invasive surgeries, right? So these are your knee replacements, your shoulder replacements, your fusions. So lipogyms really kind of falls into this, left half of this continuum, right? You can do this in the office. You can do it in a clinic. You can do it under local anesthesia. You can also give them things like laughing gas that can help to make it a little bit more comfortable for them. It's minimal downtime associated with it, but it can also be used as an adjunct to some of these minimally invasive surgeries. So what are the advantages of lipogyms compared to, a total knee replacement or major surgery for the patient? Well, one, there's no schedule delay, right? So we can do this in the office, so we can get them scheduled very quickly. No hospitalization required, so they feel a lot safer not being in a hospital, especially during the time of COVID. This is usually a one-time procedure for the majority of the patients. It's economical when we compare the cost versus the cost for a major invasive surgery. There's very minimal minimal risk of infection or complication. Over 35,000 of these have been done without any major adverse events noted. And there's minimal downtime, right? So people are able to take the weekend off and then able to kind of telework, following the next week. And they usually don't need pain medication for a very long time. And so when we talk about cost and you look at, what is the average cost for the patient for a total knee replacement, in network is usually about $4,000 to $6,000 out of pocket cost for the patient. Now, if you're looking at out of network, those costs can even be $15,000 to $22,000. And then let's talk about for the physician, for the practices. The benefits of lipogym is, if you had to put your surgeries on hold, here's a procedure that you can do that can still get the patient better and help out with their pain and function. The compliance, this is an FDA cleared technology. Research, there's over 70 plus peer-reviewed studies, and there's very little use of PPE in order to do this procedure. Now here's a slide. It just kind of talks a little bit about, where people are using this. So lipogyms is being offered at all of these places. There's over 35,000 procedures that have been performed worldwide, and there's 70 plus peer-reviewed publications. And then, once again, that minimal complication rate is a very, very important thing to kind of consider. So there was an interesting survey that they did of people who've currently used lipogyms. And out of orthopedic physicians, they surveyed them and said, hey, were you satisfied? And would you recommend this for someone who fits in that treatment gap? Out of all the physicians that were surveyed, 100% of them responded yes to that. And then we said, well, how about in the shoulder? Knees, you do really well with this. How about shoulders? About 85% were satisfied and 87% would recommend lipogyms for somebody that falls in the treatment gap for the shoulder. So we talked a little bit about the 70 plus peer-reviewed publications. Of note, that means they have up to 3-year follow-up data, and with patients that are still doing well 3 years after the procedure. 95% of this research was done as independent research. It was done at well-respected institutions and researchers. You saw the list that was just posted, and it's been published in leading orthopedic journals as well as basic surgery journals. And they haven't stopped, so they're continuing to do research. For the knee, there's currently 8 level 1 randomized controlled trials going on. There's 10 prospective studies going on and 2 retrospective. We have 3 studies going on for the shoulder that are level 1 randomized control and 3 prospective studies. There are also some other studies going on between general surgery and orthosurgery and some new investigator-initiated studies. And then we still have some studies that are going on the basic science of this, which is important because they're always trying to improve and trying to make sure that we have the best product that you're injecting in your patient and that it's going to get you the best and the most optimal outcomes. So let's talk a little bit about why adipose. A lot of people ask me that, especially, coming from the orthopedic world. A lot of people say it makes sense to use bone marrow if you're going to be taking out, something and putting it back into a joint or back into a bone. Well, the research on adipose has gone back as early as World War I, and they found that it has a lot of, it does a great job to support healing and repair. And then if we do a head-to-head, comparison of how many of the reparative elements that are found in fat compared to bone marrow, they found that about 100 to 500 times more reparative cells in adipose to an equal amount that's found in bone marrow. We also find that with fat, age might not be a factor. So some people say that, hey, we're worried about your stem cells as you get older, that they're going to be less effective. But there's been research to show that in fat, that doesn't seem to be the case. It's minimally invasive, and it's easy to get a large volume, especially with the obesity epidemic that's going on in America right now. A lot of people are more than willing to give away their fat, and you can get a large amount of volume, and that's important because if you want to treat multiple different areas, you have enough volume to do that. So once again, LipiGems is FDA cleared and compliant. It uses saline to remove the impurities. Then it gets microfragmented, and this still allows it to preserve its cellular niche. The niche is having all of the good stuff that we want to allow this to heal. And so you see over here on the the right side of the screen, this is kind of what we kind of consider the niche, right? So the niche is going to have adipocytes. It's going to have adipose-derived stem cells. It's going to have these periocytes and preadipocytes, macrophages, epithelial cells, and blood vessels. So we think that these periocytes, these are the cells that tell your body's own stem cells exactly where to go. They kind of tell the body when they've been injured and where to heal, and they kind of serve as a beacon or roadmap for your body to kind of continue with repairing itself. So LipiGems microfragmented fat. This is really the only microfragmented tissue available. All right, so it comes as intact, resized clusters that maintain that niche. And this is not a stem cell therapy. This is a fat transfer or tissue transfer. And what we also find is that this tissue transfer, they stay in the body for a very long time. They have animal studies showing that it stays in there for over a year. We find that it's the optimal size for survival, and that we use the saline to kind of remove the debris, the oils, and the blood. Those are the things that can be inflammatory. So how does this compare to other microfragmented adipose technologies in the space? Well, we talked about how this preserves the niche, removes the debris, oils, and blood, necessarily cost-effective, and it has FDA compliance. Now, when we look at centrifugation, right, so if this goes through a centrifuge, we're worried that it may create some non-viable adipocytes. We also worry about it kind of, impeding the function of some of the cells that are in there and kind of, slowing down the reparative pathway. Same thing that we kind of worry about with emulsification. So sometimes if it's going back and forth and it's getting emulsified, we're worried that you're destroying cells. And then you're also destroying the scaffold that helps to keep it sticky, it keeps it together, and keeps it functioning. And then when we come to SVF, FDA has been very clear. Once you add enzymes in order to digest the fat, that is more than minimal manipulation. So that is a no-no for FDA. So that is just, as of right now, completely off the table. And so we want to kind of avoid that. So let's talk a little bit about what does the procedure actually look like. So first, you want to select the right tissue to harvest. You want to look at your patient and see where they have a little bit of excess adipose. That's usually going to be the best place to harvest. If they have multiple areas to choose from, I typically like to choose the upper glutes. The fat there seems to be a little bit less fibrous. It's usually a little bit less bloody, and it seems to be cleaned rather easy. When I go around the abdomen, I usually seem to get a little bit more fibrous tissue there, also a little bit more bloody. Not to say that you can't use that, that's just kind of my preference, but you can take it from multiple different areas. So anesthesia is a large part of this. You want to make sure that your patients are comfortable. The more you can make your patients comfortable, the more they can tolerate the procedure, and you can get the adequate amount of fat out that you need. So we usually start off with, this is kind of our setup table in the front. You have a sterile table. This can be done, right in your office. And we start off by creating a little skin wheel. So on the slide on the left, you'll see us kind of creating a little bubble to anesthetize the skin. We'll take an 11-blade needle. We'll get through the dermis, and then we'll take our infiltrating cannula, and we will infiltrate saline with a little bit of epinephrine into the area where the fat is, that subcutaneous fat. And so that goes back and forth in a spoke and wheel-like type of motion. And then we're going to let that sit for 15 minutes. So after that sits, the patient is usually very, very comfortable. So then we can go in with our aspirating cannula. So we put the aspirating cannula in, and then we attach a vac lock syringe, and that allows us to create suction. So once we create that suction, we can go back and forth in that same spoke and wheel-like motion, and that's going to allow us to capture that fat that's sitting underneath the skin. Well, now we've aspirated enough fat, we need to clean it. So we inject it into this canister. The canister is filled with saline, and the canister contains these ball bearings. And so with the ball bearings, we shake it back and forth, try to find your inner James Bond, shaken, not stirred. And that allows us to break off the blood vessels, break off the oils, and really allow the good fat to kind of rise to the top. And that's what we're seeing over on the right-hand side, is that's the good fat that's left after we've cleaned all the blood and oil away. Now, once we have our good fat left, we attach two 10 cc syringes to both ends. And we're able to pull saline out of the bottom one. And then as we push and close the bottom syringe, that forces the good fat up into the top syringe. And that's how we get our fat into our treatment syringes. So let's talk about what are the advantages of lipogems for patients that are kind of facing a total joint replacement. Well, we talked about the research, 3 years of independent data, 70 publications. We talked a little bit about there's no scheduled delay, right? So we can do this in the office, and you can get them in and evaluate them and treat them later on that week. We talked about it's economical compared to looking at, total knee replacement. We talked about joint replacements and network can be $4,000 to $6,000 out of pocket for the patient, out of network $15,000 to $22,000. We also talked about the minimal risk. Risk is a big thing. We have so many knee replacements that are done per year in the U.S. that there's on average a 0.05% chance of death, which doesn't seem like a big number, but when we look at the total number of knee replacements done, that ends up being about 5,000 patients per year dying of a knee replacement. And that there's minimal downtime to the patient.